So if anybody's been listening to all of the sessions, the three things people, does anybody remember the other two that people call us the most about? I'm going to see who's paying attention. Seizures. What was the second one? Behaviors. And what do you think the third might be? GI. Not in that order. So actually, we'll put GI first if that gets us a little more time.
No, we're used to being towards the end.
We should go on a road show together. Yes. That was fantastic. I'll let him introduce himself, but we do have a few families that go to Dr. Bass. We could have a half-day session with him because we know GI issues are something that a lot of you don't think about with Dup, and seizures can take a priority. And then as you heard Dr. Thiebert say earlier, that sometimes the GI issues can exasperate seizures. It can look like seizures. So we are thrilled to have you, and I'll let you introduce yourself, but thank you for joining us. Thank you.
My pleasure. Thank you guys very much for having me. I have the privilege to take care of several children with Dup15q. I also have a couple with Angelman syndrome as well. And really, when thinking about this topic, you know, there's not specific great research on this specific genetic condition and GI issues, but there's a lot of principles that seem to come up often. And I really want this to be a very practical discussion and allow for there to be a decent opportunity for questions and discussion afterwards. So what I'm going to really talk about is some principles of GI care. So we're going to speak about gastroesophageal reflux disease. We're going to speak about feeding, nutrition, and growth. We're going to speak about everybody's favorite but topic that they don't want to talk about at all, which is tubes. And then we're going to talk about, at the end, constipation, because it always happens that way. And one of my, by the way, key jokes that I always ask my patients is, have you heard about the movie about constipation? And they say, no. I'm like, that's because it hasn't come out yet. So, but apparently it's hard to sit through. So I appreciate that. Thank you very much. I don't get laughs at home very much. So you know, I think, you know, reflux feeding and actually use of tubes, I think, are all really kind of brought in together. When we think of reflux, you know, you think about starting from infants with the kids spitting up. And we always say kind of all children will have reflux or regurgitate, but not all children will have reflux disease. And I think in conditions, particularly where the children have a lot of difficulty in potentially communicating what they're feeling and what they're undergoing, it can have a lot of different profound effects. It can range from extraordinary pain that is associated with feeding. It can range from difficulty swallowing, particularly children with these conditions who may spend a decent amount of their time either in a position that is not necessarily upright. They may be in a position where they're creating more reflux. And certainly we've seen children who can end up having anatomical issues from the standpoint of from the standpoint within their esophagus, and can have stricturing, which can impact their feeding. We have children who may have silent reflux, and it just kind of shows up a little bit unexpectedly a little bit later. Or the children are just irritable, and they're not having overt signs of reflux, but they're irritable, and they can't really express to you that they feel heartburn, or they feel other issues like that. The GI community has gone kind of back and forth in terms of the medications we use. Many of the medications that I mentioned here will not be new to many of you. Famotidine or Pepcid is in the class of drugs called H2 blockers. H2 blockers basically block the signal for your stomach to produce acid, and they are a good kind of mild antacid. They tend to have very few side effects and are very, very well tolerated, and a number of my patients are on these. It comes as liquid. It comes as tablets. Lansoprazole, omeprazole, commonly known as Prilosec or Prevacid. You might have also heard of Nexium or Protonix, are the class above that. And these are medications that literally block the actual acid production within the stomach, and certainly are really beneficial for healing any acid-based damage, particularly that which might be in the esophagus. And so these are drugs that we can certainly use at various times. And again, I'm giving a kind of practical overview, so I'm gonna skip on to kind of feeding, nutrition, and growth. And so really lovely talk that I just saw. And really one of the things that was really emphasized was the speech pathology in terms of communication, but also for purposes of feeding. And feeding is an extraordinarily important aspect in this population. And my experience is that it really does run a wide spectrum from children who can eat independently, and I enjoyed seeing a lot of kids doing that just at lunch. And I will be honest, the kids' stuff looked better than the adult stuff, but I'm a pediatrician, this is why. But also, from the standpoint of kids who really can't eat very well or can't swallow medications very well. One of the things that we see a lot is that particularly kids who are young, there's this drive to make them fat, happy toddlers, and this drive to kind of have them kind of gain weight as much as possible. And one of the key things that I think we always have to remember, and we talk about this in terms of nutrition, is we want to have adequate nutrition so that the child has adequate levels of vitamins, minerals, and specific nutrients. But we also want to understand where they're going to be in 10 to 15 years. And there's a reasonable likelihood that there's going to be a provider still needing to care for them. And in that situation, you want to be sure that they are not in a situation where they are unable to be cared for because of their size. Or they're very difficult to care for because of their size. It's very hard on the caretakers, particularly as they get older themselves. And so we try to shoot for, on our growth curve, about the 10th percentile, which seems to be a reasonable spot where most people can still kind of take care. So it's an important aspect to think about. It's something to discuss kind of with your nutritionist that you may see in these clinics or with neurology, and extraordinarily important. One of the other aspects is that many of these children are on various diets. For example, the ketogenic diet. And the ketogenic diet, I think, works wonders in the right child and really does things well. But we also have to remember that there's then some nutritional deficits that kids aren't getting, and we want to make sure that we are looking for those, monitoring those, and monitoring the nutritional status of these children. I'm going to skip over G-tubes for a second because I actually truly do come to that last, and talk about constipation. So there's a number of issues from the standpoint of stooling. And really what we want to be able to do is help control and help have the stooling not be out of control for a lot of children. Constipation can present quite widely. Certainly, a child who has 3 or 4 days of poop sitting in there, that is not very comfortable. It's very difficult for them to get it out. It's very difficult for many children with these types of disorders to be able to coordinate their pushing and coordinate their ability to get the poop out. And then, and if it's not going well, then that can sometimes relate back to behavioral difficulties and behavioral problems for patients. We always like to say a happy colon is an empty colon. From my standpoint, there's several different principles that I use. And it really does take an individualized approach. So, some overall pediatricians would be like, all right, try some Miralax and be done. And your grandmother will say, okay, try some fiber. And each of them have their place. I think of fiber as a mild softener. It's actually kind of a nice regulator. I think it brings your poop kind of into that middle spot where you push it out, but it's not too hard. But it also helps for kids who might have diarrhea type. And again, I apologize for talking about this after lunch. I really understand that. I'm a GI doctor. This is my daily basis. It's not your daily basis. I understand. So I appreciate you sitting through this. from the standpoint, so fiber is kind of really a great regulator. So even for kids with really, really loose stools, it actually might kind of bulk them up, particularly for kids who may still be in diapers and kind of need, and if they are kind of on the diarrhea side, could be having blowouts. You can use fiber sometimes to regulate that as well. Miralax is a stool softener. It basically is a water magnet. Each molecule of Miralax attracts so many molecules of water. It keeps that water in the large intestine. The large intestine has two functions in life. One is to absorb water, the other is to store poop. And the amount of water that the large intestine absorbs is a direct function of how long that poop is in there. So if you're going poop 5 times a day, you're going to have pretty watery poop. If you're going poop once every 5 days, it's going to be hard as a rock because it's going to absorb it all. What the Miralax does is that keeps that water in there. That allows that water to seep into the poop, make it much softer and much more easier for your child to pass. Now, just because you give a child Miralax doesn't mean that Miralax is going to make your child poop. And in some situations, sometimes what we're addressing is the fact that the child doesn't have the drive to poop, doesn't have the urge to poop, or the drugs that they're on is really, really slowing down their intestine and preventing them from stooling. So in that situation, that's where I tend to sometimes use stimulants. Typically the ones I use are either Dulcolax or X-Lax. I will tell you that there are a number of newer irritable bowel syndrome, constipation predominant medications that are on the market that I really do believe in the next 5 to 10 years we will find a utility in using them in this population. That research has not yet been done. But really what these medications do is they stimulate the colon to contract. And as the colon contracts, then that allows the poop to get pushed out. And it may give you some element of control where you can give X-Lax or Senna or Dulcolax, and then your child can have a response, 3 to 4 hours later, and then you're good for a while. So that can really, really help you in very specific situations. In some situations, the constipation can become quite extreme. And again, it's very individualized for each child. And there are certainly a number of children, even though this is not always the most pleasant thing to do, where they actually respond to enema therapy. And actually, I will tell you that in European studies, they do this a lot in Europe, and that they have a really very good success rate. And the idea, again, behind that is giving the caretaker control over the bowel movements. You have a child who really, really can't go. It causes them immense distress and behavioral difficulties when they go. You do an enema on a daily or every other day basis. You get them clear. The child is better. It's 15 minutes of difficulty to get yourself a good 48 hours of a break from that standpoint. So that's kind of one of the principles of that. And again, each is going to be need to be tailored for your own child from that standpoint. And now I want to kind of get to the idea of G tubes and J tubes. And a lot of times when I see patients in the clinic and I bring it up, the parents are like, I don't want to talk about this yet. I don't want to go there. I don't want to talk about this yet. And it's actually something I do almost on the very first visit. And the reason is to destigmatize it. The use of tubes in my world is a tool to provide a very specific clinical effect. And it can be different for each child. You have a child who they are not eating well, and you need to be able to provide nutrition for them. It gives you a route to provide nutrition so that you're not relying upon their swallowing mechanism to do it. You have a child with severe seizures and who might aspirate and doesn't swallow by mouth very well. That is a child who really would benefit from having a route to deliver nutrition that bypasses the oral pharynx and not create a risk for aspiration for them. You have a child who can eat okay, but the meds take, hours to get in, and it's a really difficult quality of life issue for the family. Or it takes them, hours to eat, even though they're eating by mouth. It provides a tool to improve the quality of life for the family. Going to a tube does not preclude a child from using their mouth. And they are absolutely able to eat for pleasure and for nutrition. But what it does is it gives you a backup. It gives you a backup so that if for whatever reason that child is unable to eat by mouth for a period of time, or is not eating by mouth efficiently, and you are not able to deliver the care or the nutrients that you need to be delivering to that child, it gives you that route to do that. And it's something that I always talk about, and I'm guessing that, again, we have probably a wide spectrum here in the audience of children who are eating well and don't necessarily need the tube just yet, to children who already have G tubes or even potentially J tubes. And really what I try to do is destigmatize it and allow for, it's never a judgment call, it's never giving up, it's never anything like that. It's really what it is. It's improving the quality of life of both the caretaker and the child by giving you a route to deliver nutrition that doesn't require the mouth. So that's kind of the way I think about it. A little bit about J tubes, or sometimes you'll hear people talk about GJ tubes. Sometimes children have reflux that's bad enough where they can't handle the reflux, and they're at risk for having an aspiration into their lungs and potential pneumonias as a result of that. In that situation, many times we will potentially pass a tube that goes past the stomach and into the small intestine. And in that situation, it provides a route for that child to get the nutrition to the area where it can be absorbed in the small intestine without running some of the risks that are associated with feeding directly into the stomach or feeding by mouth. So I know it's kind of a brief overview, and I certainly can do deep dives into all of these, but really my goal and what I really would love to have is to really now open it up for questions and have a little bit of an interplay to kind of talk about GI issues that you face, and to be able to kind of give you a sense of how I think about these types of things. So.
If we could get the another mic maybe in the back too for running. One thing I will ask on these questions, if you haven't been in some of the general sessions today, try to keep it broad enough that other people can get information from it. We had a couple people that will dive into, my child takes this twice a day, and everybody else is kind of like lulled over. So if you will, keep it kind of general so other people can get it. Marissa, are you running the one in the back, or will you or Mike run the mic in the back? And I'll start up here. Go ahead in the back, and then we'll go over here to Jen.
Okay, so I have a question. Our daughter, of course, has lots of GI issues. This will be general, I promise, Karen.
Oh, did you see me? Did you see me doing this? No, I'm just kidding.
Yeah.
Just kidding.
Yeah, so we've done the Miralax regimen multiple times, and then we at home are trying to figure out at what point do we administer suppository before having to go to the ER and have an actual enema done, which we've done once now. But the suppository for her usually doesn't take on the first round, so it may take a couple days before the floodgates open. So I'm just curious what's your take with our kiddos that have this low motility. At what point do we need to seek additional support if things are not moving?
Sure. So, I mean, certainly my goal in all my clinics is to avoid going to the emergency room at all costs, because that has, innumerable issues associated with it. Really what, from the suppositories, generally the liquid glycerin suppositories are what I will generally use. They tend to lubricate up the bottom and help that. I have some patients or families where it's easier if the child is in kind of a warm bath where they can feel that they can kind of relax their bottom a little bit. The over-the-counter, depending on the age of your child and working with your doctor, the over-the-counter enemas really do work well. There are mineral oil enemas, which will do the same thing, which will give you more of that lubrication and allow it to slide out. You're going to know your child. So, however, I generally tell parents that I would love for them to be having a regular or decent-sized bowel movement every day to every other day. And if it gets a little bit longer, not to hesitate to try to up the ante a little bit, whether it's with X-Lax or Dulcolax, because you're at 3 days, you're like, oh, they'll probably poop tomorrow, and then all of a sudden it's 5 days, and now you're like, and they're acting out and it's really, really desperate. So my goal is to try to get ahead of it once you find your spot where you're like, listen, if it hasn't been 2 days, I got to give something else. And I got to be ready to kind of allow for kind of everything to empty out at that point.
I want to ask something too and Jen, I'll give you the mic. We, in the science symposium, someone mentioned motegrity being showing a good, can you talk a little bit about that?
Sure.
And
Yeah.
For everyone who doesn't know, that is a new, I don't know if it's newer, but a new medication.
No, it's a newer drug, and it's a very, very interesting drug. So motegrity is a serotonin agonist, by which it means it hooks into the serotonin receptors in our gut. And it's a really nice drug, particularly in this particular patient population, because we have serotonin receptors that motegrity interacts with both in our stomach and in our large intestine. So not only is it going to help your large intestine push out that poop better, but it's also going to help your stomach empty. So that reduces the risk of reflux and improves overall motility for you. And so there have been isolated studies, particularly through Boston Children's, of use of motegrity in children. I still have a hard time getting it for my patients, but my sense is that that's going to be a game changer. Long ago, when I started, there was a drug out there called cisapride, or Promodal. It got pulled off the market in 2000, I believe, because it interacted with very specific antihistamines and caused kind of heart problems. And so that got pulled off. Motegrity works in the same mechanism without the complication of the heart issue. So it's a really kind of good medication.
Okay, so they could ask their doctors about that if it's something that could be available with their insurance.
Sure, and I will tell you, it's a fight. It's always going to be, that drug for right now is going to be a fight. Now that being said, particularly through this alliance, there may be opportunities to do studies. The more studies that come out, even just experiential, where like, hey, my child was on this, you report that, and then that's something that we can arm ourselves going to the insurance companies and saying, there's evidence that this helps, and that prevents an ER visit. You'd rather pay for this than an ER visit. So things like that.
I think this room could fight pretty hard for a GI pill,
No,
right?
seriously.
Thank you. So my question is kind of related from end to end.
Yeah.
So in kids that have effects with their GI pain receptors, so not necessarily because they're constipated,
right,
but just in general.
Yes.
When they have this excess pain that they're feeling that they have to be medicated for, to be able, what is causing that, and or if there's research to substantiate what exactly could be causing that pain aside from constipation.
Yeah.
And then how would using an NG tube or a G tube help to alleviate that? Because we're talking about bypassing this first area.
Sure.
If you're having that gut sensitivity, how do we avoid that? Is that the difference between the G tube and the J tube?
Yeah.
And
these are good questions.
I'm trying to get it all into one here.
These are good questions.
And then adding a drug like the one that we were just discussing, would that be a way to avoid, because I think a lot of us parents, we do everything that we can before we have to go to the root of surgery.
No, of course.
No matter how simple it is.
Yeah.
And so would a drug like this coming in maybe make us say, okay, well, maybe we should wait and try this? Or, is it beneficial to do NG tube intermediately while you're waiting for that process, or is there some downsides to that? I'm so sorry, I know that was really loaded.
That's a great question. So NG tube would be is a wonderful way to see if a child would receive some benefit from a G tube. So that's no matter why you're giving it, whether it's medication, whether it's nutrition, what have you. The one issue I sometimes have where I sometimes will bypass that process is the child really just may not like having the tube here, and so that's the because it's in the nose and you feel it a little bit. I've put an NG tube down myself in the past and you can feel it. Just to show that I could. Really the most important question I think you asked is, what is this pain? What is this thing going on? And I think of it kind of like a checklist. So it could be a lot of different things. It could be reflux, or it could be esophagitis from that standpoint. It could be stress, inflammation of the stomach, or gastritis. It could be constipation and the child being unable to kind of move things out. The other thing that happens in a lot of children is, I call it a volume of sensation problem. And what I mean by that is where something that you and I might feel as a sensation, you just ate lunch, oh, okay, I feel like a little cramp, I just like digested something. Yeah, it's a 1 out of 10. Okay, I'm fine. You know, I'm sitting here. I don't even have to. I'm stone. I'm not even changing my expression. I'm fine. For your child, that might be a 12 out of 10 or a 14 out of 10. And really, it's because these nerves are so sensitive that they're firing up to the brain, and they're telling the brain, "Hey, there's something going on here," or it's saying, "Hey, I'm digesting my food," and your child's expressing it as pain. There are a number of different medicines that we can sometimes use to try and help with that. And they range from medications like Motegrity to kind of help things empty and things flow better, to some of the, actually some of the antacids really do have a dyspepsia. They kind of help with those aspects, particularly if it's like the upper ones. Pantoprazole is one that I find really does well with pain, compared to, say, omeprazole or esomeprazole. Protonix versus Prilosec or Nexium. And then we have a number of different antidepressants that we'll sometimes use. So we generally, the one I use most commonly would be a medication called Elavil, so a tricyclic antidepressant. These are antidepressants that have been around since the 1970s. They're terrible antidepressants. They don't help you necessarily if you're depressed. But it turns out that, they do modulate your neurologic signals coming from your gut. And when they've done studies, patients who had abdominal pain with this problem had their abdominal pain much decreased on these drugs. So those are the drugs that we will sometimes give. Now, the other thing is there are also newer complementary techniques that are coming out. So there is something called IB stim. And what that is it's kind of a little sticker that has a little battery that delivers a very mild electrical stimulation to your vagus nerve. It's external. It is non-drug. And it has been shown to, because your vagus nerve is the nerve that is modulating all these signals from your gut. And the idea is that it tells that vagus nerve, hey, I'm overwhelmed. I gotta quiet down. I gotta kind of like put all my insulation on and shuttle that down. So that's something that's being offered more and more. We just started offering at our center. Medical College of Wisconsin was the place that really kind of started it and pioneered that. So there's places like that that are out there. So, but it's called IB stim. It's FDA approved for irritable bowel syndrome type symptoms, and works very well from the standpoint of pain. And we think that may have benefit as well.
Thank you. I'm going to take one more.
We got it over here, Carrie.
Okay, I can't make eye contact with anyone else then.
Hi. What do you think about the class of drugs that are for irritable bowel syndrome? There's a lot of those now. It seems like they're coming out, and they're mostly for adults.
Yeah.
But I keep seeing the commercials, and I'm like, maybe that would work.
Yeah. So Motegrity that we mentioned is one of those. There's also there's several others, and they kind of have different kind of mechanisms. There's a drug called Trulance, and there's a drug called Linzess. What those drugs do is they open up an electrolyte channel in the colon, so that causes chlorine actually to flow into the colon, and then water follows it, and so that like loosens your poop. And in some cases, it works really well. It can cause what I call the Niagara Falls of poop. Those are good drugs when they work, and you can take them and you can get an effect, and that can be a little bit of something that you can control. It's really more associated with like pain associated with it, or kind of that inability to actually get that poop out. The other drug that we will sometimes use is called lubiprostone or Amitiza, and what those drugs do is they also act on the serotonin aspects of the colon itself. So that kind of works a little bit more similar to Motegrity. So, I think we're going to find a way to use these drugs in this population. It needs to be studied a little bit, and to try and understand kind of where we might see some good benefit from that standpoint. I do think they hold some promise. My experience with them is that they're very safe and have fairly minimal drug interactions. So, but we need to be able to study them and then provide the objective data to insurance companies to approve those drugs.
Well, I think it goes without saying that we could talk to you for a while about GI issues. Thank you very much. Can we give him a round of applause?
Thank you.